There is insufficient evidence regarding the choice of treatment order for patients simultaneously suffering from knee and spine osteoarthritis that are equally symptomatic. But recently, a unique study based on a survey has attempted to address this issue. Patients may frequently have concurrent arthritic knee joint and lumbar spine disorder, and it is not uncommon that both disorders are severe enough to require operative treatment. There is insufficient evidence to guide the choice of treatment order for patients with both disorders that are equally symptomatic. Before going through a detailed review, it would be useful to have an overview of the article. 5 clinical scenarios of concurrent advanced degenerative knee and lumbar spinal disorder were designed to survey surgeons' choice of treatment order and rationale. The survey was distributed to selected clinical members of the Knee Society and Scoliosis Research Society in North America. The surgeons' choices were compared among the 5 scenarios, and their comments were analyzed using text mining. The percentage of knee arthroplasty surgeons recommending total knee arthroplasty first differed significantly among scenarios: 29, 79, 55, 7, and 81% for scenarios 1 through 5, respectively. A similar pattern was noted for the spine surgeons. The severity and type of knee deformity influenced the preferences of the treatment order in both specialists. Severe valgus deformity and windswept deformities of the knee would drive the decision toward total knee arthroplasty first. An estimated 500,000 total knee arthroplasties and 200,000 lumbar spine fusions are performed each year in the United States. Shared decision-making combines at the patient's preferences and the medical provider's assessment of the severity of disorders when both the knee and lumbar spine disorders are equally symptomatic. However, there is paucity of literature regarding the order of treatment, and the authors have managed to cite just 2 studies. The first study reported that the function of the knee after total knee arthroplasty in patients with lumbar spinal stenosis was worse than in patients without spinal stenosis. A brief review of this study shows that spinal stenosis was found to be associated with significantly lower knee society objective and function scores compared with patients without stenosis. There was no observed difference in the revision rate or radiographic outcomes. The article recommends that surgeons should caution patients that they can expect relief of arthritic symptoms following total knee arthroplasty, but they may continue to experience limitation in post-operative function relative to their expectation. The second one reported inferior spinal function scores after lumbar spine surgery in patients with osteoarthritis of the knee, compared with patients without knee arthritis. A poor preoperative functional score, the presence of preoperative knee osteoarthritis, and longer operational levels were shown to be poor prognostic factors for the one-year surgical outcome of lumbar spine stenosis. Also, patients in the total knee group showed the worst osseous disability index scores at preoperative and postoperative one-year evaluations. Consideration of these factors when planning for spine surgery could be helpful in predicting the surgical outcomes of lumbar spine surgery. In this study, the lumbar spine disorder was specified as degenerative spondylolisthesis with spinal stenosis, and the knee arthritis had different deformities. The primary research question was, does deformity of the arthritic knee influence the surgeon's preference of treatment order in patients with concurrent osteoarthritis of the knee and lumbar spinal stenosis? The survey participants were selected separately by specialty through a method of enrollment known as availability sampling in literature. Survey responses were received from 42 knee arthroplasty surgeons and 55 spine surgeons. The median year of clinical practice experience after training was 26 years for both groups. A survey of 5 fictional patients, means imaginary, unreal patients, with concomitant, equally symptomatic degenerative knee and lumbar spine disorders was devised. Participants were asked their preference of treatment order, total knee arthroplasty or spine surgery first, or no preference, the third option, and their rationale. The spine disorder in each scenario was kept relatively constant. Lumbar spine stenosis caused by degenerative grade 1 lumbar spondylolisthesis. However, the knee disorders varied. 1. Osteoarthritis with varus deformity. 2. Osteoarthritis with valgus deformity. 3. Rheumatoid arthritis with marked flexion contracture. 4. Osteoarthritis without deformity. And 5. Bilateral osteoarthritis with windswept deformities of both knees. This screenshot shows the scenario 2 as a sample. The full survey can be viewed either in the supplementary materials section or online through the 2 links in the original study. Although the use of subjectivity was permitted in this survey of experts' opinions, the study hypothesis was tested and found to be true. In both arthroplasty and spine surgeons, it was an intent to perform total knee arthroplasty first if significant deformity of knee presented. It was also notable that, in contrast to a previously survey of patients with both hip and spine disorders, the choice of the majority of knee arthroplasty surgeons was in keeping with that of the majority of spine surgeons in all 5 scenarios. The percentage of knee arthroplasty surgeons recommending total knee arthroplasty first differed significantly among the 5 scenarios: 29, 79, 55, 7, and 81% for scenario 1 through 5, respectively. A similar pattern was noted for the spine surgeons: 22, 84, 53, 13, and 78% respectively. For both specialties, the percentage of surgeons recommending spine surgery first also differed significantly among scenarios. Scenarios 2 and 5, both involving valgus deformity of the knee, had the highest percentage of surgeons who chose total knee arthroplasty first. Scenario 4, which did not have significant deformity of the spine, had the lowest proportion of surgeons preferring total knee arthroplasty first, and the highest percentage of surgeons recommending spine surgery first. Surgeons' rationale, as indicated by their free text comments, included such consideration as the rehabilitation following one procedure in the presence of the other pathology, the relative predictable outcomes of total knee arthroplasty, the effects of a severe deformity on the knee and walking, gait, pronal nerve, and so on. The most frequently used words are plotted in this figure. Only the spine surgeons were asked whether they would change their decision if the spine surgery was to be just a decompression. The majority of them indicated they would not. 82, 96, 84, 93, and 96% in scenario 1 through 5 respectively. From the surgeon's comments, the association between the presence of knee deformity and a preference for total knee arthroplasty first is likely related to the influence of knee deformity on patients' ambulation and activities of daily living. Valgus deformity of the knee appeared to be more concerning than varus deformity to both knee arthroplasty and spine surgeons. According to the authors, one reason could be the greater degree of deformity in the scenario with valgus deformity. Among the arthroplasty surgeons, theoretically, another consideration could be that the techniques of soft tissue balancing in the severe valgus knee may be more challenging than that in the more common varus knee, and occasionally requires the use of more constrained implants. Despite the level of specialization of knee arthroplasty and spine surgeons, the two groups of orthopedic surgeons had similar choices in all 5 scenarios. The overall preference of spine surgery first in the patient with osteoarthritis of the knee without deformity, scenario 4, may reflect a perception that mechanical knee pain without an aggravate factor such as deformity is usually of lesser concern. It is likely that complex deformities of the knee that cause severe pain and limitation of activities are appreciated by both specialties to have a major impact on treatment order preference. They conclude that for patients with concurrent degenerative knee and lumbar spine disorders, the severity and type of knee deformity influence the preference of treatment order among both knee arthroplasty and spine surgeons. Severe valgus deformity and windswept deformities of the knee would drive the decision toward total knee arthroplasty first. The absence of deformity of the knee typically leads to a decision of spine surgery first. Thank you for your attention.